So as described, Carbyne is basically providing emergency collaboration to advanced technologies for emergency collaboration to agencies and governments worldwide. I moved to the United States 6 months before COVID started, and I couldn't imagine, when I moved to New York City, to see the city so empty. We started to speak with agencies about our technologies that are all about getting or connecting between citizens and governments like never before. And we realized that the only industry in the world that stayed to work from their premises and didn't have the ability to work from home is the 911 agencies. So you're going to NYPD and there is 500 call takers sitting 1 meter one to each other in the same room without the ability to go and work from home. So we started to get phone calls after talking about cloud capabilities for the recent 8 years. Hey, what is this cloud? How can we move things to the cloud? How can we as a 911 agency work from home? So the biggest thing that happened in our industry when COVID started was basically funding that came in order to revolutionize the way that those call takers' infrastructure is established. So cities like New Orleans, Miami, New York, Chicago, and other Carbyne clients started to migrate their on-prem legacy 40 years old technology being into the cloud. And cloud is a great name, but it's just the first infrastructure, which basically lead into a much more exciting capabilities. For example, in all the cities that Carbyne is currently deployed, now you have the ability to video stream with the 911. So instead of saying where you are and what is happening and describe, and it's very stressful in those moments, now I can show in real time what's going on to the call taker. So this is like a small example, and then things like AI, transcription, and other things that basically change dramatically the 911 and makes government tech very excited and very exciting industry to be in, and this is what Carbyne is focusing on today.
That's exceptional. Thanks. Stephen.
So look, I don't think COVID taught us anything. It just slapped it in our face, right? I mean, I'll just give you an example. January 23rd of 2020, right before COVID hit globally, I'm a fellow of the World Economic Forum. I was sitting with the CEO of one of the big global banking companies, JP Morgan, and we were having a cup of coffee. He said, you know, 40 years ago, the two sectors that escaped the consumer revolution were banking and healthcare. And then he took a sip of his coffee and he said, now you're alone. Now think about this for a second. Like, we don't get up in the morning and say, I think I'm going to tell a bank. It's just that banking went from 90% in the bank in a very inconvenient way to 90% at home. 40 years ago, we would have worried about people lining up at the bank to deposit their checks. So the way I look at emergency services, one of the things that's so exciting about Sheba is that Sheba and Jefferson became almost twin sons of different mothers because we stopped looking at our hospital as the definition. We both call it healthcare at any address. So the way I look at emergency services is more like unscheduled care. And what I tell people as it relates to our emergency services, and this is what's great about the companies coming out of Sheba, is I want people to get unscheduled care as conveniently and as close to their home, starting at their home, as they can. And both at Jefferson and at Sheba, based on companies that we've been able to help form together, whether that's being able to test blood pressure and other things at home, we can get almost 50% of people that might have gone to the ER before to get it done at home. So if you came to my office at Jefferson, we had 750,000 ER visits throughout our 18 hospitals. We were able to get half of the non-trauma, non-ambulance ER visits out of our expensive, inefficient emergency room, and either done through urgent care, telehealth, or an appointment the next day. And for those that were naysayers, because a lot of times, I'm a doctor, I'm a high-risk obstetrician, and we think, oh my God, everything we do is so special and nobody else can do it. But even something like appendicitis, right? I did early appendicitis. We were doing things, especially during COVID. My wife has left lower quadrant pain. Do me a favor, Mr. Jones. Could you press on her left lower quadrant?
Right.
Okay, press hard. Does that hurt? Yeah, that hurts. Could you let it go? Okay, does that hurt more or less? Well, that hurts less. Okay, you do not have a ruptured appendix. Okay, now that we know you don't have a ruptured appendix, Mrs. Jones, could you get up and do like 3 jumping jacks? Okay, if you can do that, it doesn't mean you shouldn't be seen. But not everything that we do where you're waiting 5 hours, and there with the trauma people needs to get done in a hospital. So the concept of healthcare at any address is something that both Sheba and Jefferson believed in.
Stephen, you remind me, one of my surgical colleagues told me, during the pandemic, I taught my patient the McBurney sign. I think that's how you call it, right? That's how we were taught in medical school, press and release. And that's
a quick anecdote. My daughter got pregnant during the pandemic, right? She needed 3 non-stress tests a week. And she had to go to the hospital, and she said, Dad, I had to spend $35 to park 3 times a week, go to a place where there are a lot of sick people, so I can go up in an elevator, so I could stare at the ceiling and somebody could monitor. I thought you were the digital dude. Can't you take care of that? And there's a company out of Israel that we're actually working with at Sheba called Nuvo that is starting to do obstetric monitoring outside of the hospital. That's going to help so much. Why do you need to go to the hospital for those kind of emergent things?
incredible. Thank you.
I think
the Israeli experience.
Yeah, well, I think for us, COVID has changed the way people in Israel see the emergency centers, because we had the best campaign any organization could have asked. The Prime Minister came on public television and told the people of Israel, listen, if you came back from somewhere abroad, or if you are coughing, sneezing, or in general not feeling so well, do nothing, call Magen Adom. Now it's February, March in Israel, the mid of winter. Who is not sneezing, right? Who is not feeling well? My Jewish mother, if she is not feeling sick, then she's not feeling alive. So suddenly, from 6,000 calls per day, we got to a situation where we have 80,000 calls coming per day. Now, let me tell you this. Technically wise, we were ready, because our systems are designed for really national challenges, earthquakes, wars, terror attacks. So the technology wasn't the problem. The challenge was to reinvent ourselves each time and time again. Because from being used to responding to emergencies, heart attacks, strokes, car accidents, suddenly somebody calls you and says, listen, I need a COVID test. Can you help me with this? And yes, we ran the PCR home testing. But then we found out that there are several several communities that don't want to be tested at home, because then their neighbors think that they are sick. So how do we reinvent ourselves? We will open up drive-through centers, but now we have to technologically adjust our systems or create system that supports this. So our coders, our 60 coders, had to work through the night. But not only this, people are not coming to the drive-through centers because they don't have cars. People in Bnei Brak, they don't drive. So let's reinvent ourselves, take them to the drive centers with the ambulances. And when COVID decreased a little bit, people are not coming today to be tested in Israel. I just got the report. We had about 30 people coming to antigen test yesterday. So what do? You reinvent yourself. You do what we call COVIDio. You have, remotely supervised testing through video. We do this when somebody says, I have a laceration in my leg. I tell him, show me the video so I can instruct you of what to do. So why won't we do this with COVID? So it was reinventing ourselves, thinking out of the box, and understanding that today's out-of-the-box thinking is tomorrow's box. And on the following day, you need to rethink out of the box. And I think, once again, the biggest advantage that COVID brought is that it made the emergency centers a one-stop shop. you're not only calling when you have a medical emergency. You call in when you feel sick. You call in when you need assistance, and Magen David Adom will assist you in any way. We tend to put the patient in the center, right? Everybody believes in this. Are we really putting in the patient in the center? Or when he calls and says, I have a heart attack, we'll send you an ambulance. Or when he says, I have a ruptured appendix, I'm telling him, no, that's not me. Go somewhere else. This is what COVID did to us.
Great. Thanks. No, I think that the theme here is that COVID, as bad as it was, in Hebrew you said, me'az yatsa matok. With it was terrible, still terrible, but made us think, made us push forward, and we are coming up with a thing that's going to serve us well in the future. Thank you. So let me ask the three of you, and I don't know if we're going to have time to take some question afterwards, but what other disruptive technologies or changes in paradigm you envision, you see on the horizon that you think will kind of force another revolution in the emergency medical care?
So Carbyne vision is basically to save lives, minimizing response time and maximizing efficiency. In order to save lives, we believe that the way that people interacted with emergency services up until today will change moving forward. For example, I believe that most of us have smartwatches, Alexa in our house, Siri in our car, and kind of a smart devices that are, in certain cases, smarter than a human. We believe that unhuman initiated capabilities for connecting with emergency services will be the big thing for the future, and we're already introducing those kind of things. So there is companies like Vayar that, for example, have the ability to recognize old people that are falling in the bath without the ability to call now to emergency services because they phone it in the living room. We will have the ability to connect them with emergency services, including to the apartment number and the exact location, without the need for the human to actually do something actively. Same thing if you're driving your car and for God's sake there is a car crash, so automatically share all the data, including the heat and the injuries, etc. So this will be one big change that it's already happening. And on the other side is basically we are trying to eliminate the human intervention in the system because human making mistakes. So we are, in our platforms, have a lot of AI capabilities, learning from 500,000 calls that we have roughly per day, and basically building protocols in order to automate the response. So if you have a car accident, 2 cars involved, there is blood, we are transcripting all the voice coming in, and based on what the person reported, right, we are creating protocol for automatic dispatch. So automation and more capabilities to connect into 911 eventually will, save more lives and, shorten response time. So this is Carbyne focus, and this is what we are doubling down on for the next few years.
Looking forward. Stephen.
I think there are three, and it's all of which we're starting to do at Sheba. One is just to take what you said, the next concept of wearables. Right now, people have 5 Oura rings and 3 watches, and you can hardly wear anything, and you have different apps. I think what we'll have in the not too distant future is that your shirt or my t-shirt or your shirt will be monitoring everything that we're doing. So nobody will die of atrial fibrillation at 2 o'clock in the morning, because if their heart rate goes up to a certain thing, there will be an automatic message, an ambulance, to your point, will come, and that person, or there will be someday nanotechnology that will just inject the right medicine. So the concept of coordinated wearable that's constantly monitoring you. My car gets better care than I do. My car literally stays in the garage, sends continuous signals out, and then I wake up in the morning, I turn around and say, hey Steve, before you go to Starbucks, my right front passenger tire is a little low, could you fill it up? Meanwhile, in 2 weeks, I'm gonna get a physical exam, and my doctor's gonna say, Steve, today, on February 1st, your blood pressure is X, your calcium score is Y, we did chest x-ray, this is what you should do for the next 2 years. So I think that's number one, the concept of continuous things. The second thing that we haven't talked about yet is the whole behavioral health revolution, especially post-COVID. That's an epidemic. And what we found, and I ran a two-campus university, especially among young people, they would much rather talk to a bot that looked like them than a psychiatrist that looked like me. If you're a 17-year-old African-American student, you don't really want to talk to a 69-year-old guy that looks like me, and you don't care if it's a bot. So the concept of starting to literally look at how we can help to treat behavioral health on an ongoing basis. And then the third, which is a company that I'm very involved with, and again, that Sheba is doing a lot of technology in, is the whole issue of drone delivery. You know, you get out of the emergency medicine department, you need certain things. Instead of having to go to the drugstore, it'll automatically be drone delivered, especially if you're in a rural area. So I think continuous wearables, behavioral therapy, and sort of chatbots, and then drone delivery are the three things I'm excited about.
Thank you very much. Please.
Well, I'll take it to the point that I ended earlier. I think that the era where when you had a medical emergency and you called the 911 or the emergency center, they would react, the dispatch would react, we are over it. We learned during COVID that people tend less and less to go to hospitals. They prefer to stay at home rather than be stuck in an elevator and getting COVID themselves. And I think the emergency centers are going to change their face, and from a reacting mechanism that they serve now to become a mechanism that runs the medical situation somebody encounters. In my view, in Magen David Adom's view, we want to have a situation where if you are not feeling well in Israel, call Magen David Adom. Now tell us what the problem is. We can send an ambulance if you are suffering from a heart attack, which will take you to the best cardiologist in Israel, Sheba Hospital. But if you are suffering from a non-emergency, we can send Magen David Adom ambulance with a telemedicine to perform medical examination at your home, including blood test, including even today we can have an ultrasound testing, whatever is needed, and connect you via video or teleconference to a doctor and let the doctor decide whether you should go to a hospital. We believe that about 70%, 7 out of 10 patients don't need to go to the hospital nowadays. But we keep sending them because the mechanism today is you'll call in, we'll take you to the hospital. With the technology that was mentioned here, with changing the paradigm that the hospital is the location where a patient should be, we can get to a situation of most of the people stay at home, in which most of the people stay at home. Now imagine what it will do to the overcrowded ERs that we already have. Imagine what it will do to the offload times of ambulances. We nowadays have ambulances that spends 2 hours at the hospital without offloading their patient because there are no beds. If 70% out of them will stay at home, we'll have more ambulances available, we'll have the real patients being taken care of at the hospital and the rest being taken care at home. And at the end of the day, we will need emergency centers that are more prone for technology. Ours is. Magen David Adom's emergency center is prone to technology, but we'll have to make it much larger. We'll have to do emergency center staff much more minded, not only to emergencies, but also for daily calls. But I'll believe that when we'll all meet in IAC 2033, we would say, how come we used to work otherwise? We have to have, telehealth or emergency medicine that looks at the patient himself and not at the cause of taking him putting him here or moving him there.
And if I could just say one thing, I mean, since this is the Israel-American Council, and since I'm American, I think Israel can be so proud. I know, at Sheba we have what's called ARC Chicago, where 6 health systems are learning from Sheba how to do some of these things. We have the same kind of thing in Jersey City with the Hospital of the Future. So, Israel is, in essence, especially as it relates to unscheduled care and some of the innovations that you both have talked about, is a net exporter, and there's almost no other country in the United States, because we have a pretty big ego, in the United States, but, there's no other country that we say, yeah, come on here because we can learn so much from you. So as my mom used to say, it should give you great nachas that you're coming to the United States and doing all these things.
Absolutely, and to your point, I'm a proud graduate of Sackler School of Medicine. Also, the Sackler name is not as much revered these names, but the Tel Aviv University. And I attended medical school more than 30 years ago, and we had the Safta B'Mizderon, the old lady in the hallway. And I think what you just all described is the solution to this ongoing scourge. Finally, we'll get the end to this scourge. But I think that we should come out of this discussion as very encouraged that great minds are working to make us safer and provide us with improved emergency care in the future. So thank you very much.
Thank you.